there's lovely posters in the rooms that say, ask me if I've washed my hands. And I observed someone come in and do some stuff on the computer, do something else, touch their hair, and then they went to, I said, oh, excuse me, can I just check, have you washed your hands? The look of filth I got.
Welcome to the Perioperative Medicine Podcast. I'm Jamie Smart. Today we're going to be talking about consumer advocacy and the important role of including patients and their loved ones in the process of designing new policies, processes and models of care. My special guest today has both personal and professional experience in this area. Belinda Macleod-Smith has a leadership role with the Victorian Department of Health, and through this and a variety of other organisations, she's been involved extensively in consumer advocacy and co-design within the healthcare system. Belinda, I know you're very busy. I really appreciate you making the time to join us. So if you're comfortable, I'd like to start by hearing about the personal experience that you and your husband, Mark, had in the healthcare system.
Thank you so much, Jamie, and I really appreciate this opportunity to have a chat. And I love that you're taking this focus on lived experience. It's something that is clearly very close to my heart, no pun intended. And I think just to share a little bit about my experience and what brings me here to be sitting and chatting about this in a podcast with an anaesthetist of all people. I guess I'll start with the most important plot spoiler. So my husband Mark had a heart transplant, and we're actually, next week he celebrates his 10-year anniversary of transplant.
How good's that?
Which
Fantastic.
is, and I like to say he's a thriving heart transplant recipient. One of the things that I've learned along the way, along this journey, is that if I start at the beginning of his story, people get quite anxious and stressed because it's quite a complicated story with a lot of ups and downs. So I do like to start off with plot spoiler. He's here and he's going well. So that's a really fantastic outcome. And for us, it's been a 15-year journey when I look back. So it started with Mark having congestive heart failure in 2010, and that's when our children were 4 and 7 years old. And I just mentioned that as part of our experience of this journey has been through supporting a young, so for me, supporting a young family plus my husband at various times on a very complex journey.
There's a lot going on.
There is a lot going on. Mark, with the congestive heart failure, just kind of, this is like cliff notes, he was very unwell, had a massive heart attack, was airlifted, implanted then with an internal cardiac defibrillator, which the hope was that the heart would remodel itself with rest. That was very hopeful. Unfortunately, with heart failure, sometimes what's on the box is what's in the box. He became progressively unwell with a number of things happening, thyroid storming. He needed surgery to remove his thyroid. And then we had an incident, which I'm going to unpack a little bit more later on, which is actually the incident that helped me find my voice and what kind of led me to this pathway. And I would say that the 5 years before transplant and the first few years after were probably some of the most challenging experiences, not just clearly for Mark as the patient, kind of living the dream, but just as the carer, navigating the system with a young family and it all being very new. Mark was 40 when he became, so plus we're just sharing his age, sorry if he's listening. So we were at a stage of our life where that was not on our bingo card at all. Yeah,
I'm sure. So that was a lot going through. And you were interstate at that time, were you, or you made the move over here?
So we're originally from Adelaide, and something that I learnt that really piqued my curiosity was that Adelaide is technically regional when it comes to complex cardiac care.
Yeah.
So every time something acute happened with Mark, he was originally airlifted to St Vincent's in Sydney, where he received his care at the start of his journey. And then as things became clearly what was going to be needed, a transplant, we actually advocated for his care to be, when I say we, it was me. I'm quite persistent, to be transferred here to the Alfred, because I'd kind of scoped where could we live as a family and what was going to be
That's an
easier.
Incredible lot to be going on in your mind. I mean, most people I think would just say, okay, if that's what you say, that's the best thing for me. This is where I'll go. But for you to have all of that insight and that calmness, I guess, to work out the big picture It's quite amazing, really.
Yeah, well, my husband would say that I'm a lifelong control enthusiast. So this is, I guess, making things happen. And for me, for both of us, the value that's very much driven us is that we promised our kids that no matter what would happen, we would stay together. And if we didn't all come to a city where we could live together, then we wouldn't have been keeping our promise.
Okay, and you're still here.
Yeah.
The transplant. What year was Mark's heart transplant?
So that was in 2015.
Oh, you said it was the
2015.
10-year anniversary. That's a lot of time that Mark was unwell, and then going through that whole transplant process. A lot of exposure to the healthcare system, whatever that is, the healthcare system in 3 different states. And I'm thinking that when patients are going through a process like that, and particularly in intensive care, it's difficult for them to have their own voice.
Absolutely.
So what was your experience of that, and how did you find that process of being an advocate for Mark, or how did it start?
Yeah, well, I mentioned before there was a particular incident, and I think I often do reflect that we've had the very best experiences of our lives and the very worst experience of our lives in hospital corridors, ICUs, and in fact, the start of me being a really, really difficult spouse, which I mentioned to you earlier, is after Mark had one of his initial surgeries, he was not doing so well and he needed to have an inotropic infusion. And I remember sitting and watching. We had it in a private clinic at a large hospital in South Australia. And I remember watching the nurse do it. She put on some gloves, and then before she placed the needle for the infusion, she tore the fingers off her gloves and was feeling quite vigorously for his vein. Didn't think anything of that. But a couple of days later, Mark actually ended up with very severe sepsis. He already had a heart issue. So the sepsis, which, look, there's no evidence or proof that that was the cause, but I do remember at the time watching and thinking, oh, that doesn't seem right, because I didn't see them wash their hands. I didn't see. It's like, oh no, they know what they're doing. They're the experts here. And it just bothered me so much that I'd potentially missed, not that I felt responsible, but I did feel responsible. So I guess at that point of time, just because sepsis is not fun, and severe sepsis is particularly not fun.
Particularly when you're as unwell as Mark was.
Yeah. Congestive heart failure is not a great lead-in for sepsis. But, as I said, plot spoiler, that was a really difficult 40 days in ICU where lots of things happened, and he ended up, that was the point where the only option left for us was potentially for the Alfred to be able to pop him onto an LVAD left ventricular assist device, if his kidneys recovered. There was lots of ifs. So I had a lot of time to think about what I would do differently next time, and even in his treatment for that extended period in an ICU, it is a very challenging place to not be a clinician in an ICU. But in terms of finding my voice, I think then and now it's just not about me. It's about what can I do to help Mark when he can't speak for himself, even though some people would say the dynamic seems the same actually, whether he's in a coma or not. You do seem to do most of the talking.
You do speak for him, okay. Well, he must be very comfortable with that and very grateful for everything you've done. Tell me about the difficult spouse thing. We were talking about it before, but how did you find out that you were a difficult spouse, Belinda?
Well, so often when you are in hospital a lot, there can be some familiarity with people get to know you, you get to know them, you get to know the health service. Even though I didn't display that on the way in here, I demonstrated my absolute lack of memory. But we had a couple of situations when Mark had come out of surgery, for example, and he'd be wearing an allergy bracelet. It'd be like, what allergy has he got? And it's quite difficult sometimes to find out the information. There is a little bit of a, you don't need to worry your head about this. Like, let the professionals take care of this. And I guess I asked a lot of questions. Again, for me, advocating for my husband and for other people, it actually is life and death. So if it is uncomfortable, or at the start I used to be quite shy. There was a time where I was a quiet spouse, but Mark had come out of a surgery and I was just curious about the surgery. Had taken a lot longer than what was expected. There was no one around to ask questions. He was still dozy, and I thought, I'll just have a look at his records. That was when, probably showing how long ago it was, when the patient file was at the end of the bed, and I was just reading it, and it was in there that I was a difficult spouse. So,
right. And how did you feel about that?
I thought that's an interesting thing to put in records, to have in a written record. And I actually remember thinking, good, I'm glad. If difficult means that people are braced to hear from me, that's great. I've got a background in strategic communications and public relations, and when you say no publicity is bad publicity, it's like, okay, you're expecting something. It's worked against me sometimes. I won't lie, Jamie. It's not.
I guess the question is difficult for who, and if someone reading that might take offence, but then you could look at it as saying, no, what they're saying is, this person is making me feel uncomfortable by asking uncomfortable questions. You've said a few things earlier about, when you first noticed about the drip going in, when you said you thought, oh, well, I guess they know what they're doing. And then you were talking before about how the feeling that you had, which was just, don't you worry about it, leave it up to us. They're big things to overcome, aren't they? I would say most people would struggle with that. And a lot of health professionals would struggle with people stepping through that. Is that what you found?
Absolutely, yes. And I have embraced there is a saying in consumer advocacy, not just in health, but first through the brick wall gets a bloody nose. So I've certainly had some bruising encounters. And I have had an experience here in Melbourne where when Mark was on the LVAD, there's a lot of tubes and drainage. I was responsible for all the aseptic wound dressings, so there's another skill I've got. But at one of the checkups, I kind of, there's lovely posters in the rooms that say, ask me if I've washed my hands. And I observed someone come in and do some stuff on the computer, do something else, touch their hair, and then they went I said, oh, excuse me, can I just check, have you washed your hands? The look of filth I got. So I kind of think it's interesting that, yes, it is challenging, and sometimes it's hard enough to actually get the courage up to say, oh, excuse me, person responsible for keeping my husband alive, I'm just going to check something. Mm-hmm. That wasn't a great experience for me. The person was very snappy, and it ended up not being a really great visit. And I'm always conscious too, even though the Charter of Healthcare Rights states that your care will not be compromised if you speak up.
Just thinking of that.
The reality is that it's also uncomfortable for clinicians. Like, it is uncomfortable. And something I learnt from being an on-staff consumer advisor, that's a role that I've been fortunate enough to have here in Melbourne, is that seeing the other side of the curtain, that if you are experiencing staff who have those attitudes, it's highly likely they're not working in a safe culture themselves, or that's the way they've been trained, or that's the behaviour that is accepted.
But you still, you don't want to irritate that person and then leave your loved one in their care and
Correct.
Walk away thinking, have I made this situation worse? That, I like your analogy, the brick wall, because that sort of divide between the patients and the healthcare staff. I guess that's where that's what has to be broken down, and I guess where consumer advocacy comes into it, and we'll talk about that shortly. And I wonder if some of that comes from old attitudes. We know best, doctor knows best, don't you worry about it. And we need to see a generational shift, a generational change where healthcare professionals are more conscious of what patients want and what's best for them.
Yeah, and it is a two-way street though, Jamie. I would say for every consumer that is like me and is willing to speak up and speak loud, what the system needs to think about is are the consumers and the family members who are quiet or actually don't have the ability to speak up. One of the things that has really kept me active in this space and working at not just at the bedside. I like to think I started off being gobby at the bedside and I've worked up to being gobby at a state level. Like it's a real ambitious career plan. But what I think about other folks, when we were often in the waiting rooms, many clinic waiting rooms, I often was able to advocate for Mark because I have some levels of privilege. I do have a background in comms. I can be articulate and confident. There's nothing like a middle-aged white woman to really speak to the manager. But I would look around the waiting room and think, well, that's not very fair. I'm sorting things out. What about the people who are actually older folks who actually would never speak back or question their medical professional? So, yeah.
Yeah, that sort of leads me on to my next question, which was I was thinking about from your personal experience, what was it made you think that you could be an advocate for other patients, or if not, to help guide others to have their voice heard?
It's a really interesting question. It probably is just that sense of equity and fairness, that if I could do it for Mark and being on that transplant journey, just having that privilege. To be honest, when we first came to Melbourne, we didn't have anywhere to live. I'd left a business behind in Adelaide. I didn't have job networks. So I started off with volunteering. My first volunteering gig was I thought, I need to find other people who are on this journey because this is going to be lonely and hard. I knew that. So connecting with others through volunteering, the Heart and Lung Transplant Trust here in Victoria. I started off there volunteering as I met other people on the transplant journey and realising that I could do more in terms of peer support, in terms of communication, education, using some of the skill set that I had, transferable skill sets, to actually benefit folks on the same journey.
It's great hearing your story, and I want to, if we could now, want to move it on to just the whole concept of consumer advocacy, because one of the themes of this, particularly this year in the podcast series, is we're talking about the way you go about making change within the healthcare system and to try and empower others in the healthcare system to make change and to realise the steps involved. From my experience, the voice of consumers, who are our patients basically, is often overlooked or perhaps sought late in the process. Maybe a basic question, but can you tell me what is consumer advocacy and what role does it play, do you think, in developing new models of care?
Yeah, so that is such a great question, and if you ask 10 different people, you will get 10 different answers. So my personal approach is, the great news is there is nothing new under the sun. This kind of advocacy work has been going on for literally decades, so collaboration, co-design, and working with lived experience actually has really deep roots in the disability sector. Nothing about me without me. So health consumer advocacy, if people want to learn more, we mentioned a document before, the Australian Charter of Healthcare Rights, really great place to start. Understanding individual rights, but also the responsibilities that the system has to make sure those rights can be met. So consumer advocacy can be seen, some people will call themselves a consumer advisor, a lived experience advisor. One of the things that we can agree on is that we don't agree when we talk about consumer leaders, consumer representatives, but essentially the purpose is the same, to make sure that lived experience perspectives are included in system planning from the bedside all the way up to the board. So in Victoria, we have the Partnering in Healthcare framework, and that's just a little plug. That was something I was lucky enough to be involved with. I was the consumer side of a consumer clinician pair that was put on board to develop that statewide policy. So that is a piece of work that looks at, what does this look like? How do we make it true? For lived experience to be present in system design, what does that look like from the bed through to the boardroom, through to state-level governance committee? I have very dear friends who sit on consumer advisory committees at a national level, at a federal level. If you look at any of the big colleges or other regulatory bodies, they will have consumers embedded in their governance processes. And I probably sound like a real policy nerd, but again, we've got the national accreditation standards, the two foundational standards. We have clinical governance and we have partnering with consumers. So anyone that's truly curious about how to do this, there is so much information out there, I don't know if that completely answers your question.
No, it does, but it leads me to another question, which is, so say I'm designing a new model of care. What can I expect a consumer advocate or someone with lived experience to add to my process? Why should I involve them? What are they going to bring to it?
Yeah, well, the first question you should ask is actually, what can you expect of yourself, and how much of this process and the design process, and you can be as honest as you like. There are some processes that won't be fit for purpose for co-designing. So I always encourage people, how much of this decision making are you going to give to lived experience? Genuinely, who holds the decision? What lived experience will bring is so many different levels of benefit. And I would give as an example, a really, really simple example of, I was at the health service that I was embedded. We had a problem arise where there were people constantly late for a particular clinic, and they were trying to figure out, using those kind of improvement science models, the 5 whys, why is this happening? It was a really long way from the car park. People were mobility impaired, and it was just actually taking them a really long time to get to the clinic. What the staff thought would be an amazing idea is that they should get like some golf buggies or a shuttle to pick people up to bring them to the health service. They ended up having just a very informal, because we can't bring together a committee, what can we do? I said, well, we could offer them a coffee and ask them what they need, which is sometimes it's a simple intervention. And sitting down having a coffee with a group of folks that were at the clinic, they were like, oh, we don't need that. It would just be great if the parking that was available, if there was more parking, even just a 5-minute and extended drop-off zone. So rather than practical things from that level all the way through to the sensitivities of how care is provided and the kind of things that people want. I think about some of the very acute scenarios that Mark's been in, even when he was on an LVAD, and we had the opportunity the supplier of the LVAD wanted to meet to find out. And they asked, well, why have you got it in that bag? That's not the right bag. The bag that they provided, because it was quite a heavy unit at the time, was a one-sided sling. So painful, he was ending up with referred shoulder and neck pain. So him and a number of the other folks that were on an LVAD had actually kind of sorted out for themselves like a backpack scenario that kind of tucked everything away and the cords didn't get caught. So from a design perspective, from a comfort perspective, lived experience can bring a lot, just so many different things to a project.
I guess that sort of leads on to my next question, answered a bit too. I'm thinking about at what point we should include consumers in this process. And I'm just thinking of a recent, it was a recent change to a policy here at the Alfred Ad Department was involved in, and the whole thing was put together. This is what we're going to do. It was all the key stakeholders, apart from consumers, were considered. Branding was done, logo was done, and then it went to the patient experience group, and they basically said, we don't understand your logo. It might make sense to you. You're using words in it that do not make sense to us. And I was thinking, what a lost opportunity. So I'm thinking the answer will be the earlier the better.
Absolutely. And that is, yes, 10 out of 10, that is correct. So essentially in the redesign of any process, if you have a look at co-design principles, first of all, you look at the phrase I said before, nothing about us without us. Does the process or policy you're developing impact or does it touch consumers, patients, carers' lives in any way? If it does, better to get them in early, and just to be really, as I said, just be really honest about how much influence you're going to let them have over the final decision. And there's a whole bunch of different decision matrices and engagement frameworks. I know at the Alfred, most major health services do have a framework for participation, but just make it a zero bullshit environment. Don't offer a decision if it's not. Yeah. Don't pretend that there's choice.
Do you find this? I mean, you've done this before in various committees, but do you find there's a wide range of acceptance of your role and of the input you can have?
Absolutely. We and again, I have like a little posse of advisors, and we work at all different levels. And sometimes it's kind of it's really we're trauma bonded just through working with different boards that run that spectrum of people who I've worked with. I'm working on a project continually actually around post-intensive care syndrome, and I've been involved right from the start with this amazing researcher. Professor Kimberly Haynes, just dropping her name because she's amazing, but right from the start, she has included me. Not only did I design the logo and help with the name of the program, she has all the way through been so open and participant. She actually ruined me a little bit because I've gone on to have experiences where people aren't as inclusive. She's a co-author on her papers. I've been involved as a chief investigator for some of the research. These are things I never had anything to do with before. But, it varies.
Yeah, I'm sure it does. I just wonder if that attitude of, look, when doctor knows best, healthcare knows best, we will, we'll include consumers partly because we have to. You never know. They might have something to say, and then like a shift to saying, what you're saying, basically, your involvement early can set things on the right path. It can have a significant impact for the consumers at the other end.
And let me be clear, sometimes that is the correct approach. I would not expect to be, when Mark has been in acute life and death situations, when he had to be put on ECMO, where there was a very short amount of time, that is a 100% trust situation. If you tell me there are two options here, life and death, and you can offer me life, yes, absolutely, I will listen to everything you have to say.
Excellent. What I'm hoping is that people listening to this, there may be some people out there that actually would like to be involved in consumer advocacy. I guess some people have it and some people don't have it, or everyone has probably got something to contribute. What do you think it takes to be a consumer advocate?
I think, first of all, know yourself, the level that you want to be involved with, and it will grow. So the most important thing you can do as an advocate is to understand how to advocate for yourself first, because those principles and approaches of understanding what your rights are, how to speak up firmly and with courage about your own, that is where you will build and grow those skills. As you work through the system, and because there is a discrete skill set around being a consumer advocate, there is knowledge, there are professional skills associated with it. So I think start where you are, and as you build confidence, like any kind of role, think about where you want to be. So for me, I'm a big problem solver. I was always curious about in the same health service, we can have the most magical, delicious unicorn experience, and then the next week in a different ward, so different. So I'm obsessed with variation and how you resolve variation. So my pathway is very different from other people. Yeah, depends what you want. I want to influence change.
So if anyone's listening and interested in finding out more about consumer advocacy and how they can be more inclusive when designing new models of care, are there any resources you can recommend? You've already touched on some, but anything else that you think would be useful for health professionals?
Absolutely. I think every state either has a current or some version of a state peak body for consumers. Depending on if you want to connect with those bodies, there's the Health Consumer Centre here in Victoria. But also I would actually start, this is again nerd alert, if you look in the accreditation standards, the Partnering with Consumers, the workbook, it is a thing of beauty. It articulates exactly what it looks like. So there's plenty, what did we say before? Just Google, honestly. Just Google.
We'll put some of these resources up on our website too, which is PeriopMedPodcast.org. And those resources would be there. It's been a fascinating conversation. Are there any other areas that you'd like to touch on?
No, it's always great to chat about and reflect on the journey. And if people are looking to get into this area, whether they're clinicians or consumers, because the thing is, it's always better together. So working together, we will achieve more than separately. So that would be my final statement.
Belinda, thank you again for coming in, and thank you so much for sharing that personal story. Pass on my best to Mark, and wish him a happy 10th anniversary. Are you doing anything
Yes.
special?
Oh, absolutely. We're doing exactly what he wants, which is a very, very small gathering of just family and very close friends just at the local pub because we can.
Fantastic. That'll be great. Well, enjoy that, and thank you once again.
All right. Thank you, Jamie.
The Perioperative Medicine podcast series is produced by the Department of Anaesthesiology and Perioperative Medicine at the Alfred and Monash University. If you have suggestions on how we can improve this podcast or any questions for us, please visit our website at perioppodcast.org. Thanks to all of our guests on this series, and a special thanks to Dylan Kodatuaku, who records and uploads each episode.